All right, so I'm not going to overwhelm you with going into a detail of value-based purchasing by any means, because that's a lot. But what I really want to do is just provide you with a little bit of an overview of value-based purchasing and how it relates to the HAI component within the measurement domain. Because I know that many of you are leading teams and engaging in quality improvement, and perhaps even sometimes you'll have your executives will come and we'll talk about where your hospitals have landed with value-based purchasing and all the CMS required measures. But, you know, it's just a mechanism in which to have good conversation and start the momentum for change, I think. So that's what I really want to talk with you more about this. In my former role, I was Associate Chief Nursing Officer in the Duke Health System. And, you know, I was first introduced to value-based purchasing from this end of the portfolio with, you know, how much money are we losing and what's the impact, and we have to, you know, get a control on infections, and we have to, you know, work on HCAP. That was a lot. But then when I was a nurse manager, I was in the Wake Med system and then also at Wayne Memorial in my career. I really got more indoctrinated in how it relates to your outcomes of care and how to use this information to drive change. So I think what I'm going to do is just really engage you in conversation with me as we go through talking about this and how you see you might be able to utilize some of this information to drive change, especially if in one of your challenging areas is perhaps having conversations with the leadership, looking at opportunities to invest in more resources. Those are the kinds of things that this perhaps could give you some insight in. So let's begin. So the background behind all of this, obviously everybody knows about value-based purchasing in hospitals. We've been in it a long time. The one component of this is that in the Affordable Care Act, CMS stated that they wanted to be applying payment adjustments with FY 2015 discharges beginning in October 2014 in the HAC reduction program. And so in FY 2018, hospitals that ranked in the worst performing 25% of all of the subsection would then receive a 1% payment adjustment that could have been otherwise paid. What does this mean? It means that this weighs heavily into that overall value-based purchasing. And if your hospital is in that lower quartile of performance with amongst other hospitals in the nation, that 1% could translate into millions. So I know that this is a you know, kind of a big hairy deal, and a lot of people gripe about CMS because, you know, they can't get their methodology straight, and we're already dealing that with star ratings and everything. But I feel in the value-based purchasing, they pretty much have this solidified in the evaluation and measurement criteria. And if you notice in the safety domain, that's the area we're very interested in working more with you on this opportunity, especially in the CLABSI and CAUTI. Now let's celebrate. I think we do good work in other areas, especially like with our MRSA has come a long way. Our hospitals have done an excellent job in instituting antimicrobial stewardship. We've seen a dramatic reduction in SSI, and our PS90 or our event harm has gone down as well. So I think we've done a really good job. It's really cracking the nut on these perceptions that we see with the CLABSI. And that's why we're brought together today to talk about this. You know, what are some of those situations? Our patients are getting sicker. Case mix index doesn't matter in the value-based purchasing. They do look at that from that standpoint of, you know, this patient here in this hospital and this patient here in this hospital, same risk adjustment, should they be having the same inspection? So as you can see here, 25% of that domain can add up to a sizable chunk. So the updates to the HAI measures per se in CMS They looked at all the new baseline for the CDC, NHSN, or CMS, that they were changing the baseline in that to update their risk modeling at that time. So the changes that onset prevalence rate outliers for all of their core greater than 2.6. Designation for MRSA model, and they expanded. Already heard from Heather reporting that. Now, I thought it would really have a chance to coordinate. Heather was able to share the between ICUs and because as you can see, data we saw that originally in 2018 they limited to those ICUs. The 2019 you can see that's expanded out to the surgical wards, the medical surgical wards, and the pediatric wards. So we got infection practitioners here today. Yes. So I know that in many hospitals, the infection practitioners will do the mapping and make sure these units are mapped correctly. It's very important with the value-based purchasing component. Because if a unit, for instance, is reporting on infections in a telemetry unit or step-down unit and it's not included in that, you know, you could be having some errors in terms that in just the reporting of it. Here we are today. We're actually moving in. So value-based purchasing is 2 years in arrears. Remember that. So we're here today in 2018, and we're actually in our performance period. It's ending in June and in December. In some of the measures, they all kind of have different time frames. But 2018 is your performance period for your 2020 payment. Bizarre, right? So you're like 2 years. So you think about it. So in 2021, that's when next year, we're going to be starting our performance period. So always remember that. That always used to drive me nuts when I was trying to do improvement, because I would be seeing my improvement in real time when I was working on the CLABSIs and the CAUTIs in the units, but you know, we get a report and the administrator would be like, oh, you know, we had to pay another penalty. Well, yeah, you know, it's 2 years. So let's celebrate the now and know that that'll translate into a return on your investment in 2 years from now. But you can see that the measurements in the domains, and I've already seen a window. I went to my national meeting with my other fellow colleagues at HRET, and I saw that, you know, in 2021, it still looks like that definitely that safety domain is still going to turn to 25%. The mortality is another to a 50% weighted mortality today. But you know, point out how important this is. Google. Do you guys get a share? Do share that with you in your meetings? How many? Right now. Okay. So just a hand that if you're doing quality improvement, that you utilize the framework. You know, got plenty of webinars on it, but having conversations with your leaders. So breaking down in that performance period and the domain weight, one, which is a modified 90 composite measure. 19, you know, you see the same thing. Now, what does that mean? It means that they just changed some of the harm events that they're going to be looking at. So, for instance, sepsis is coming in there. So they're going to be looking at sepsis. So those are the kinds of other components within that. And then in your domain 2 is where you have your CLABSI, CAUTI, SSI, MRSA, and CDI. Now, the key here to remember is that if you're a small hospital and you don't have enough of those events, so those kind of negate out, and your weighted score goes up for your other areas. So just remember that. I'm sure everybody here, certainly you have events, but that's one thing we always remind our smaller hospitals that are still in the value-based purchasing, that we do have some that don't actually have some of the CLABSIs or CAUTIs, or they're so small, or they don't have any of those designated areas that NHSN designates as target areas. So, but domain 2, your CLABSI and your CAUTI weights at 85% versus domain 1, which is your HACS, is 15%. So this is a big contribution to that safety event area. So this just kind of talks through the measures on where they have been over historically, over 2015, going up to 2019. It's important to, already realize, again, all of this is done, it's a done deal, but the recalibrated PSI-90 was started in 2018, 2019, and then we continue. So there's no change. They're not going to be retiring any of the CLABSI and the CAUTIs and the MRSA, any of those measures. So now I want to talk a little bit, how does this all work? Because it's quite a complicated process. But so there is an end of the reporting quarter where each quarter data is being uploaded into the CMS warehouse during the performance period. And then they also, too, at the same time, NHSN has about a 4 to 5 months from the end of the reporting period to submit and review your data into NHSN. And this is a time where you can submit and review, and you can make corrections into NHSN, right? However, CDC, what CDC does with CMS is they take a snapshot of an immediate of the close of the submission deadline. So when you submit, they take a snapshot. You can review an NHSN, you can make adjustments. CMS, however, takes a snapshot, and that's what's calculated. So if there has been errors or there's things in there, that does not get accounted in CMS. So lessons learned, be diligent, review that data before it's being submitted into NHSN to make sure that the data is accurate. Because unlike NHSN, CMS does not have that window. You can review it and you can see what it is, but if there's errors in that data, they don't have that same ability to correct. And you have a 30-day, CMS only gives you a 30-day review window. And you don't have to worry about this because you have plenty of folks that are reviewing, auditing, and looking at that. But you work in concert, right? So if whoever is reviewing that NHSN data, it's really important that that's accurate mapping and all of those things are accurate, because that's how CMS will review and make that calculation. So CMS calculates the CLABSI and the CAUTI, the SSI, the MRSA, and the CDI, HAI measures using chart abstracted data and submitted via hospital through to the NHSN. The half reduction program reviews in the correction period does not allow the hospitals to correct the following: reported number of HAIs, SIRs, or reported central line days, urinary catheter days, surgical procedures performed, or patient days. Those are those important key areas I just kind of alluded to. So stage 1, reviewing your data measure. Like I said, you have the 4 to 4.5 months after the quarterly report ends to make sure all of this gets corrected. HAI data that have changed in NHSN after the submission date will not be reflected in the CMS hospital compare. Stage 2, eligibility report. This is where hospitals have So what are you going to be looking at specific to the HAIs that you want to review and you want to see during that period? The reported number of HAIs, the SIRs, and the reported central line days. So I also have referenced, you'll see a whole list of information if you want to dig into this more. This is just really major day, this whole conversation. But I would encourage you to think about looking at some of those resources that are listed, at least peruse through them to get a better understanding on this. So the CDC will share that data on behalf of the participating hospitals to CMS. CMS prescribes to the quarterly deadline, and that's how the snapshot is done. Data for a given quarter are considered frozen, and then the program will reflect multiple quarters of data that's used and each frozen period for the quarterly deadline. And so here's just the list for value-based purchasing. So I split this out for just the overview of value-based purchasing. Now I'm going to go into really more of that actionable period that I think you'll be interested. Well, how do I use this data? How is this one of my tools in my bag to have these conversations? So why analyze the data in NHSN? Well, I've always found that the data is very informative for internal stakeholders to, bring together a group to point to, you can't argue what you're measuring, right, and what you're seeing in the data. To facilitate HAI data validation activities and inform and prioritize success of prevention activities through the use of the reports. So it's a great tool to begin to do that root cause analysis in the deep dive. How many of you do root cause analysis currently on each infection that you do? Perfect. Are you using your NHSN data? Incorporate that in there. I'm just curious, how do you use it outside of the root cause analysis, maybe to drive a conversation? Where else are you using your NHSN data? How do you display it? How do you use it to create the change? Anybody want to share?
Well, each of our units we publish a monthly scorecard that has the CLABSI, CAUTI, the device utilization, their hand hygiene, their isolation compliance, CDF, MRSA.
That's good.
And you can see it's not just one unit, it's the whole breakdown for the organization. So they can see why there are other.
That's good. Yeah, that's great. Now, let me ask you this question. Let's go one step further. So then, if you see a spike, then tell me kind of what's your process for kind of doing that change. You want to share?
Group that meets monthly, and it work on those specific infections, and then also our infection prevention committee. And then we have sometimes, if there's a special issue going on within our organization, we had issues with CDF several years ago.
Yep.
So we had working on HAI CDF.
Great. That's excellent. Excellent way to use it. Anybody else maybe use it in a different way or want to share? Yes, ma'am.
Like Julia said, we share our SUR data. I give them the graph. The specific unit is units in NHSN. So we're typically higher.
Mm-hmm.
That is something that we've been two different types of, one for male and one for female, giving them other options, because it was that we had trialed a specific type of external catheter several years ago. It didn't get approved, and our staff really liked it, and they said, please bring that back, please bring that back. So it makes a difference.
Great. That's excellent. That with, you know, it's a great way to use the, everyone utilize, looking at this, thing it to celebrate too when you're having. So the general analysis, as you know, in the NHSN, but certainly don't limit yourself, is looking at other number of different types of reports that are helpful in looking at how you're doing overall, like line lists. What kind of lines are you using? How frequently are you inserting them? Where is the insertion? Frequency tables, using graphical charts to display this. SIRs, continuing to utilize that as URs. And then the device statistics. I think what Heather talked about today and looking at the mean and looking at the mode and the distribution and seeing where you fall is another good way to utilize that in kind of your journey and your goals. Some of the changes to the data, what changes can potentially impact your SIRs? Well, the entry and the edit and the deletion of events. So those were what I spoke about when we were talking about how the quarter ends with NHSN and you get a period to review, but they're already taking your snapshot and sending that off to CMS. So prior to submission, it's important to review and make your changes before it goes to NHSN. Changes to number of patient days or device days or admissions can change the data. Removal or additions to your MRPs, changes in admission dates, previous discharge dates on lab ID events, and changes to relevant factors in the annual survey. So things like medical school affiliation, facility bed size, all of those are components. And then resolution of report of no event alerts. So some of your daily quality checks that you'll want to look at are the monthly reporting plans that you complete in NHSN. Are they being done? Are active locations applicable to NHSN surveillance listed? Are all the appropriate procedures selected? Are the appropriate lab specimens selected to collect for lab ID data? This is just a review. I know everybody knows this, but it's important to remind ourselves what goes in and what can be affected by it. Are the number of beds updated from the previous survey year? You know, that's the other thing is that now with hospitals being in such a bind, you know, you have licensed beds, but then you also have staff beds that you have to consider. And how has the hospital's medical school affiliation changed? Have alerts been resolved for the required analysis months? So you see those alerts coming into NHSN. Are new data sets generated? And were events entered after my analysis? So just a good inventory check if you're the one going through this NHSN component and responsible. General tips for data quality. Just know your number of patient days. Are you guys also looking at patient days and reporting that out in your data set as a whole? Yeah, great. Number of admissions in your hospital each month, device use locations under surveillance. And so this is important too because this is expanded out into the medical wards. You want to make sure that the diligence that the ICUs have been doing for years, that we're doing the same diligence on those units that are under now part of the value-based purchasing. So again, you can reference, I put a reference in there if you're interested in learning more. Now we reference the APIC calculator, that's fine. It's good to introduce it. I'm going to introduce it from a different perspective. When I was a nurse manager, a lot of times I would be very frustrated because I needed some support, some investment, device change, and I didn't know really how to articulate it well. And I wish I would have had some of these tools and these opportunities to learn about this But I can tell you that Claudia and I, we were like, wow, this is really cool, because everything is an ROI, right? What's the return on the investment? How much is it going to cost? How much is it going to save me? What's all that data? That's just the way we work when you're in the C-suite. That's how we have to look at things, because we don't have a money bush right outside, so we can't do all of the things in the wishes list. But this really helps, because you could go in, and if you have this information, that's great. But if you don't, it's already embedded into the intelligence of the tool, so it brings the literature cost to for reference. But you can look at your admissions per year, and then how many patients had HAIs in the last year? Do you know your attributed cost for the HAI? So some of this you might not even know. That's okay. You can fill in what you have. You will know your infections in your area, and then you can just plug and play that in, and then it gives you these really cool reports. And so this is just a snapshot. We just played around with it. But you can look at your total annual infections, you can look at your total annual hospital days, and you can look at your costs. And I can tell you that can be a real game changer. And this really speaks volumes. And CEOs, CFOs, chief nursing officers, we look at data and we make decisions based on these things. And so I think with you being able to articulate through your root cause analysis, utilize your NHSN data to show those trends, making recommendations, and then substantiating it with, a handy tool like this could really, accelerate where you need to be. So, questions. I have resources that are listed here on the second component of what I wanted to talk about, with the specifics to the hack and the calculator and everything. Anybody online have questions? Could you see yourselves maybe using some of this now in your conversation? Was this helpful? A nice review? Okay. Well, great. Well, thank you.
I'll just put a plug. So most of you should be aware, but if anybody is not receiving their monthly reconciliation report, yes.
Is this working? Okay. So most of you should be receiving, but if you're not already receiving, please come and let Savannah know. The SHARPS program produces monthly reports that are data quality reports
for hospitals, and it's just a line list of what we're seeing, so you can check to make sure things have been entered the way you think they have been entered. We also run some quick data quality checks, so if something is flagged as a potential duplicate event, we try to highlight that for you. And those are run only on a 60-day delay, a 2-month delay, so that's a great way to review your data before it gets pulled for CMS.
That's great, Heather, and I think everyone knowing that there's that resource from you guys will really help a lot as well, too.